At the outset, I'd like to say thank you to the organizers of this meeting. Wonderful attendance. And the first one. I think over a period of few years, you would have noticed that, I don't like talking too much about statistics. Believe me, at the end of any conference, nobody remembers any of the statistics which goes around, because each of the speaker has around 6 trials which he has specifically picked up, and you have 150 speakers, all interesting topics. So we need to have a take-home point. Before going into DEB, I'd like to take a step backwards. I'm always a skeptic. Peripheral arterial disease, here to stay, aging population, increasing diabetics. We are going to be in business for a very, very long time, and we need to start handling our patients much, much better. Though we had this statistic saying that, within 5 years, more than 50% of our patients are dead. Initially, it used to be 2 years, 30%. Now it's 5 years. But I think with better medical technologies, including renal failure patients, they tend to live a little longer than what they used to earlier. So it's not just one factor. It's not one drug-eluting stent, drug-eluting balloon, or a specialized stent which is going to keep the blood vessel open. Treat the patient as a whole. Do not concentrate only on that lesion over there. So what are the options we have for treating any kind of peripheral arterial disease? You have the medical management, essentially for claudicants, yes. Optimal medical management remains the bedrock of any kind of treatment. You have endovascular treatments, POBA, stents, different types of stents, drug-eluting balloons, various other techniques. And we are all vascular surgeons. We all think and we know that the bypasses work for a little longer than an endovascular procedure. Gap is closing. And we have enough evidence with various newer trials. Now, let's not get into surgery or endovascular procedure. Our enemy, whether you do an endovascular treatment or whether you do a surgical treatment, is neointimal hypoplasia. What basically, as soon as you do an angioplasty, the initial recoil you get is because of the recoil. You're not able to adequately open up the blood vessel. But anything which starts happening later is always neointimal hypoplasia. Neointimal hypoplasia is actually physiological. It's the healing process of the blood vessel to any kind of injury. So to say we can prevent neointimal hypoplasia is going against nature. And you can't go against nature and win. You can postpone the inevitable, but you cannot prevent neointimal hypoplasia. Always remember that, irrespective of what anything say, the body is always and nature is always 100 steps ahead of you, and let's just feel good that we are able to postpone the inevitable. So you do a POBA, you get neointimal, you can get an immediate recoil, but in the longer term, it's always neointimal hypoplasia. You put a stent, you get neointimal hypoplasia. The timing differs, but you do, and that is the reason why most of the SFA interventions fail. But does it mean that, if I do a bypass surgery, my neointimal hypoplasia is not going to be there? Yeah, it's going to be there. At the anastomotic site, you're still going to get a neointimal hypoplasia. The body reacts in such a way that anything which is not native is always destroyed, or it occludes over a period of time. So you put them on a surveillance and then you catch them before it really occludes. But neointimal hypoplasia is our common enemy. So basically, when you do a angioplasty or when you disrupt the blood vessel, even when doing a surgery, what happens is there is a breakage of the internal and external elastic lamina. We always seem to concentrate only on the endothelium as well as the media. The adventitia slowly has been proven that is most potent thing in repair of the blood vessel, and most of the stimulus does not come just from the endothelial breakage, it comes from the vasa vasorum. So adventitia also has a major role to play, and it's the smooth muscle cells. One, it has two functions like Elan had already mentioned. One, it starts multiplying, and then it starts becoming secretory. And using the drug-eluting balloons, you're trying to reduce the multiplication as well as reduce the secretion. You reduce it, but you can't stop it. Now, all of you are surgeons out over here. We've all seen how neointimal hyperplasia looks. When you've done a redo surgery, it's like a plug. You do a thrombectomy, you get a white plug out over there. Now, my doubt, I always keep arguing with people. This is a neointimal hyperplasia in a stent which was formed around 2 years back. That has got occluded. Now, that has already gone through the multiplication phase, it's gone through the secretory phase. And now you're going to put a DEB. I have a doubt over here. Now you're going to put a DEB and say, I'm going to reverse something which took place. So basically, when you're dilating, keeping it dilated for a longer time, so you're going to compress that like sponge and you're going to drive out a lot of things. But you're not going to prevent. What you're going to prevent is further neointimal hyperplasia. But what is already there is a little dicey. Unless you debulk it, it becomes irrespective of what the data says. This is a physical lesion which is already there for 1.5 to 2 years. You can't say that it will go away. And just because some trial says it goes away, you have opened the artery, you have seen how it is on the inside. So, this podium gives us a good reason for us to discuss a lot of things. And I think it's a wonderful initiative. So, this is my main problem. What happens when it's already there? So like somebody said, de novo has a better result than following a previous procedure. Now, how do you prevent neointimal hyperplasia? Do not go into the drug directly. There are a lot of things. See, what we need to remember is the kind of patients we deal with and the kind of patients that the studies present to us are completely different. They will not recruit a patient if the HbA1c is beyond 8.1. Most of the studies. And very few of our patients really fall into that category. Most of their patients are claudicants, not that they don't treat. So we have a different, so optimal medical management, optimization of the patient is of paramount importance. So let's not just think it's just endothelial hyperplasia or you giving certain drugs is going to reverse all the things. Systemic medical therapies, we already know about it. Statins, higher dose of statins does have a role to play. And cutting balloon in the primary stage itself, instead of uniformly dilating the blood vessel and fracturing all over and then causing disruption all over, you fracture it in certain places, get luminal gain. Maybe that was what was taught earlier. Appropriate sizing of the stent. Don't oversize the stent tremendously. This is to try and, in our existing practice, to try and limit the first addition of neointimal hyperplasia. Are there a lot of other strategies too? Yes, there are a lot of other strategies which have been there from before. Some have fallen by and some are coming back again. You have COX-2 inhibitors, gone. TNF alpha inhibitors, again to reduce the inflammation, gone again. DEBs and DESs are there. Again, you have other strategies. You have the gene therapy coming back again. 2 Israeli companies and 1 Canadian company, they're coming out, it's there in endovascular today. And in the device guide, they're coming with vector-based therapies, which again, maybe 5 years down the line, we'll be having a conference like this saying that, newer technologies to prevent neointimal hyperplasia. Bioabsorbable scaffolds have already come in. Lot of polymers have come in. You have, like Ilan had already mentioned, progenitor cell injection directly. So basically what happens is you try and repair the endothelium. Once the endothelium is completely formed, all this process of multiplication and secretion comes down. So they did try this, coming back and going back again. Endoluminal brachytherapy, I had seen it in the coronaries being done in our institute itself, long back, known to reduce it, but again, didn't have good long-term results. There are a lot of other devices which have come in, which have tried and reduced the incidence of neointimal hyperplasia and keep the luminal gain going for a longer time. Now, in brief about the various trials. Now, at the end of this talk, you must know that, DCBs are definitely better than POBA, and it definitely gives us luminal gain and maintains luminal gain for a much longer period. The safety and other things, there are other papers which will come up with it, but definitely various trials show that at the end of 3 years, previously all the data used to be at 1 year, now you're going up to 3 years, sometimes up to 5 years. Try and remember the names at least, forget the statistics. It's very, very difficult to remember all the statistics, and we can always pick holes. And even at the end of 3 years, if you have something like 75%, that's phenomenally good. But all these lesions were less than 7.5 centimeters. Again, complex setting where there is occlusion, narrowing, calcification, like some of the slides which are shown by Vijay Thakur, you can't use DEB in the entire segment. So you need to tailor a program for the lesion. So how do you deal with eccentric calcification? How do you deal with circumferential calcification? We all know where to put DEB. I'm sure towards the end of it, we need to have a session where not to put a DEB. You have Monkeyberg calcification, you put a DEB, I mean, you're only giving him business, and that guy will know that, you know nothing, you're just interested in putting a balloon. You cannot achieve any good results when there is Monkeyberg calcification. So how do you identify that? When you see a X-ray. So when you start reading the calcium scoring, you will know where to put what device and do it appropriately. Various trials, like I told you, safe DCB register, then you have the Thunder trial, Levant 1, Levant 2, all these things definitely showed that you have more than 75 to 80%, and in Levant 2 study, at the end of 12 months, you had around 89 or 90% at the end of 12 months, and at the end of 2.5, 3 years, some of the reports have come out, almost 70%. Pretty good, stays open for a much, much longer time. But in patients who have uncontrolled diabetes and in patients who have renal impairment and who have severe infection, do these DCBs work just as efficiently? There is a huge doubt being raised about it. I mean, if you look into critique of any of these papers, just look into the other part where they give a commentary, you find that it's not as rosy as what they claim, but definitely towards the end of 3 years, you have a fairly, almost around 50 to 60% improvement in this patency compared to a POBA. So regarding drug-eluting stents, I'm sure the other speakers will come to it, various trials, and try and keep the dosage of the antimitotic drug at the minimal, because the last of regarding the toxicity has still not been said. We still have to go some time. By the time we get real results, it will be another 3 to 5 years. You also have the Ranger SFA trial. Again, similar results, sustained over a period of 3 years. Again, FPAC trial also says the same thing. So basically, what does it say? At the end of 3 years, depending on the type of trial, you get at least 75% patency at the end of 3 years, provided the lesion length is between 7.5 to 12. Best results are less than 7.5. 150 balloons are available. But again, if you go into the individual segments, if you have more than 15 centimeters, it does not stay open beyond 18 months. 50% patency. So this subgroup analysis, unless we come to forums like this and somebody puts their mind into the statistic, we start believing that 75-90% applies for all the patients. No, it applies for certain patients. Again, these are the references. I think all of us, a lot of youngsters over here, my age group people, we had this a cosmetic called Fair and Lovely. So we tried to apply it and think that, we could become fair and lovely. My hair turned white, my face didn't turn white. Okay, you do get the same thing, looks very good, but after a few years, nature wins and it's back to the same thing. Okay, so does it work? Of course it works. Do you need to be selective? You have to be selective. I always like to quote these kind of things where there is a lot of division among ourselves. It's like this. mutual fund investments are subject to market risk. Please read the offer documents. This comes in fast succession, but believe me, this is very, very important. You have all the data, but you also have the intellect not to believe a guy who comes and tries to sell you a drug who has not completed his degree, or he might have just completed a degree. He is a salesman, fine. Listen, there are a lot of scientists who worked around it, but please look into our patient's condition, whether we are going to achieve the same kind of results what they achieve. Thank you, ladies and gentlemen.